Good afternoon, my dear colleagues and friends at BGICC 2021. I wish I was there in person to be with you. Inshallah, next year I'll be there in Cairo. I am so honored to be here with you virtually. Of course, my dearest friend, Professor Hashem Al-Ghazali, for putting together truly the preeminent conference in the Middle East and North Africa and around the world. I am super thrilled to be giving a few talks today, and I look forward to a really great discussion in the sessions to come. I'm going to share my screen and start the next talk, and this one is on the management of in-breast tumor recurrences. So I currently serve as the Deputy Chief Medical Officer for Surgical Services at Yale and the Director of the Breast Program and Professor of Surgery and Oncology at the Yale Cancer Center, Yale School of Medicine. You know, this harkens back to the days where we were traveling together and sitting together, and this is an evening in Cairo looking over the Nile, having a wonderful dinner with all my colleagues at BGICC. And again, God willing, when COVID passes, we'll be together next year in person. So when we talk about in-breast recurrences, I really think that we need to now start slowing down and thinking about various options for our patients. I want to go over a little bit on local recurrence, the regional recurrence, the management, and some kind of concluding statements. So local recurrence is a reappearance of the cancer or new primary on the ipsilateral chest wall of breast, just basic definitions. Regional recurrence, tumor involving the regional lymph nodes, usually ipsilateral axilla or supraclav or infraclavicular and inframammary node, but usually ends up being the axilla. I think the management is very complex and layered, requires multidisciplinary assessment. And the treatment has the potential to provide long-term disease control for patients who really develop isolated local recurrence after breast conservation or mastectomy. I think there is a difference between the mastectomy patients and the breast conservation therapy. Usually there's earlier recurrence in the post-mastectomy radiation. The median has been 2 to 3 years as opposed to 3 to 5 years for breast conservation. Often on the mastectomy, it's on physical exam. More likely to involved in the mastectomy setting, regional lymph nodes, and more likely to have distant metastasis and poorer breast-specific survival. And breast conservation therapy recurrences can really be true recurrences or a second primary. The truer recurrences have a higher rate of metastatic disease and poorer prognosis as opposed to the longer term second primary. There are multiple risk factors. The major risk factors are the number of positive axillary lymph nodes, the size of the primary tumor. Others are the patient age, the hormonal or receptors, and the HER2 status, presence of LVI, whether there was extracapsular extension, positive margins at the original surgery. Local recurrence after breast conservation with radiation therapy. So if there was no radiation and the patient underwent breast conservation, those local regional recurrence rates were fairly high. It's about 10 to 40%, but you could really consider this to be a standard of care for women over the age of 70 right now with estrogen sensitive disease, early stage 1 or 2 breast cancer, is to do breast conservation without radiation therapy and the consideration of endocrine therapy. The usual treatment could be surgery and, if appropriate, adjuvant chemotherapy or neoadjuvant chemotherapy, hormonal therapy, or targeted therapy. Radiation should be considered if you're going to repeat breast conservation when radiation therapy was not given. If there is distant metastatic disease or local extensive recurrences or wound control problems, you could consider palliative mastectomy, but often if we could get systemic therapy to lower that burden of disease, that'll go a long way in helping local therapy. Looking at the elderly without previous radiation therapy, I think the CLGB trial from Kevin Hughes 9343 has really provided so much wealth of data. Looking at women over the age of 70, clinically no negative, lumpectomy to negative margins, tumor size under 2 centimeters, usually ER positive disease. Some did have axillary nodal surgery, others didn't, randomizing to radiation and tamoxifen, or tamoxifen alone after breast conservation. We looked at in-breast tumor recurrence rates, and certainly, yes, the additional radiation therapy significantly reduced that, statistically significantly reduced that from 91 to 98%. However, the time to subsequent mastectomy really did not differ. And more importantly, there was also no difference in survival. So yes, radiation will lower in-breast recurrences, but the ultimate risk of final mastectomy, second primary breast cancer, distant recurrences, or dying of breast cancer really remain the same. How about breast conservation with radiation therapy? A meta-analysis of 17 trials for women over age of 40 undergoing breast conservation therapy in the modern era. Local regional recurrence rates are very low, under 5%. Most patients, if possible, if they recur, should receive salvage surgery. And about 85, almost 90% of the time, these patients are operable. I think the standard is mastectomy. And if there is involvement of skin or inflammatory, then we really want to try to decrease that burden of disease with systemic therapy prior to surgery. Looking at salvage breast conservation, those numbers vary in the literature, but I think you can probably say between 15 to 30%, I would say, would be a second local regional recurrence after salvage breast conservation therapy. I do think mastectomy is still the standard of care, but in a certain subset of women, we should be able to consider this as an option. I think when to consider this: breast conservation and radiation therapy for primary breast cancer treatment. If there was when you look at the group of breast conservation and radiation therapy, their preeminent study, I think, that originally kind of gave us some background to this was from our colleagues in Milan at the European Institute of Oncology. Gentilini and his colleagues, Veronesi, looked at really kind of two big groups of tumors. One was those that were less than 2 centimeters and recurrence rates for over 48 months from time to relapse. And then the smaller tumors, again, less than 2 centimeters, less than 48 months from time to relapse. And there was a difference in terms of the second local regional recurrence of 15 versus 31%. Who's not a candidate? I really think those that have genetic mutations, multicentric disease, really large tumors, these could be candidates for clinical trials. So looking at our European counterparts in Milan between 1997 and 2004, nearly 300 patients with operable invasive ipsilateral breast tumor recurrence after breast conservation with whole breast irradiation. 161 of these patients underwent a second breast conservation procedure. Median follow-up was 44 months. And the 5-year cumulative relapse rate was 31%, which is high. However, when you look at this for tumors that were less than 2 centimeters and the timing of the in-breast recurrence, if it was greater than 48 months, that number was much lower than if it was a really quick recurrence within the first 48 months after surgery. On multivariable analysis, what are some of the factors associated with local disease-free survival? One was the size of the tumor. Next, as we saw, was the timing of the ipsilateral recurrence. And that also was seen in the disease-free survival portion and overall survival portion. Looking at local disease-free survival, again, I think it's the size of the tumor and the timing. The 5-year cumulative incidence of a second recurrence was only 15% if this was an extended period of time, again, greater than 48 months, as opposed to a quicker local recurrence of less than 48 months. The KLOR-RX group, led by Dr. Irene Wapner, on the poor prognosis after second local regional recurrences. Looking at this flow chart of their patients who underwent either, this is treatment of the primary breast cancer and the site of treatment of isolated local regional recurrence. if you look at those that underwent breast conserving therapy and those that underwent ipsilateral breast tumor recurrence, and then going on, most underwent salvage mastectomy, and a second local regional recurrence was only seen in 6 patients. They did have 16 patients that attempted repeat breast conservation, and those recurred in 2 of those patients. And when you go down the route of mastectomy, well, most were chest wall recurrences. Most underwent chest wall resections with the use of radiation therapy, and in 5 of those patients, there was a second isolated local regional recurrence. When you look at the factors associated with this adjuvant chemotherapy was the strongest factor that was seen. So how can we improve local recurrence after local recurrence and possibility of disease-free survival for those patients who undergo repeat breast conservation therapy? Certainly the role of radiation and the use of partial breast irradiation. And I really thank my colleagues, Dr. Alphonse Tagian at Mass General and Dr. Jennifer Bellin at the Dana-Farber for providing me the kind of the slides and the background for this. For accelerated partial breast irradiation, the ESTRO working group study has been underway, looking at 217 patients who underwent lumpectomy. This was a European multi-centric retrospective study. The median recurrence tumor size was 11 millimeters or 1.1 centimeters. The median time was actually relatively long. To recurrence was 9.4 years with a median follow-up of 3.9 years. The 5 and 10 year second local regional recurrence rates were actually relatively low, 5.6 and 7.2%. Really pretty robust overall survival. And the conclusion of this study suggested that in breast tumor recurrences with lumpectomy plus MCB is feasible and effective in preventing second local regional recurrence, and the overall survival rate was at least equivalent to those that achieved with salvage mastectomy. There are other methods of radiation. One is catheter-based or interstitial implant, low and high dose rates. Dr. Vicini has a very large experience on that. And the re-radiation, if was going to be attempted in salvage breast conserving therapy, whole breast radiation is a standard for primary breast conservation if they did not receive radiation therapy. In general, it is not recommended for repeat breast conservation with a whole breast radiation. Current RT practices for salvage or repeat breast conservation therapy is really not well agreed upon, and you could either consider accelerated partial breast irradiation or interstitial brachytherapy. And these are probably fairly equivalent. Regardless of the technique used, limiting the field and the duration appears to be beneficial both for the toxicities of repeat radiation therapy and outcomes. There are intracavitary application methods outside with mammocyte and many others out there, and those are being studied in multiple settings in the United States and around the world. Certainly, we can consider electrons in those centers that have it, in patients that are undergoing repeat breast conservation therapy. Intraoperative radiotherapy, again, in those centers that have it, is something to consider. 3D conformal photons and mix. Again, a lot of this experience comes from our counterpart, Dr. Vicini at Michigan. I think the last portion, which really we won't have time to go through in great detail, is the axillary management after initial breast conservation. I think patients should undergo repeat axillary evaluation if there is concern for ipsilateral breast, if there is an ipsilateral breast tumor recurrence and there's no prior axillary lymph node dissection. You could consider repeat sentinel lymph node biopsy if they've undergone a repeat sentinel lymph node biopsy. I think the data supports the feasibility of this using dual tracer. And you should consider, if you have abnormal pathologic lymph nodes and that are biopsy proven, to consider actually really doing an axillary lymph node dissection. If they've had a prior axillary lymph node dissection, if clinically negative on exam, really no further therapy. Repeat sentinel lymph node biopsy, the identification rates certainly are lower. There's aberrant mapping that we have to be concerned about, but it is something that can be considered in the appropriate setting. Certainly those that have had, for example, a sentinel lymph node biopsy after mastectomy, those identification rates are really low. So this is really a lot to cover. It's a very fascinating area with many areas of exciting research. I think putting all these pieces together is that post breast conservation therapy, one, recurrence rates are usually fairly low. If it's after breast conserving therapy, it's usually image detected. The timing of the recurrence is usually slightly later than mastectomy, which is found on clinical exam. Diagnosis and pretreatment evaluation. The diagnosis evaluation of a suspected local regional recurrence should include a full staging workup to exclude distant metastatic disease, which potentially would preclude local therapy. I definitely think biopsy is warranted to confirm that this is a disease recurrence. The expression of hormone receptors in HER2 may have changed. This could tell us whether this is a true local recurrence versus a second breast primary. This is from Dr. Cardoso in Annals of Oncology, and I think it is very reasonable to look at local regional recurrence after breast conservation with radiation therapy, that the standard is mastectomy. However, considering breast conservation therapy in appropriate cases, after mastectomy without adjuvant radiation therapy is wide excision and local regional recurrence. After mastectomy and adjuvant radiation therapy, complete excision if you can appropriately re-irradiate, and then using the pseudoadjuvant chemo and or endocrine and or targeted therapy. I hope that was clear. I know this is an interesting picture. This is Hong Kong from the Mong Kok side looking at Kowloon. Again, I hope we can be together next year. I thank you for your attention. I really look forward to the discussion later this afternoon. Thank you so much. Take care.